Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Julie Brahmer, Director of Thoracic Oncology at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins in Baltimore, Maryland, and Dr. Jarushka Naidoo, a consultant medical oncologist from the Beaumont Hospital, RCSI University of Health Sciences in Dublin, Ireland. Together, they will answer questions asked by the audience during a live CCO webinar on evolving immunotherapy strategies for patients with early stage or advanced non-small cell lung cancer. This episode is part of a larger educational program titled Understanding the Evolving Immuno-Oncology Treatment Paradigm in Non-Small Cell Lung Cancer. For more information on Dr. Brahmer and Dr. Naidoo, along with a link to the complete program, including downloadable slide sets, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Hello, I'm Dr. Julie Brahmer. I'm the Director of the Thoracic Oncology Program at the Johns Hopkins Kimmel Cancer Center in Baltimore, Maryland. And with me today is Dr. Jarushka Naidoo.
Hi there, my name is Jarushka Naidoo, and I'm a thoracic oncologist and lung cancer lead at the Beaumont RCSI Cancer Center in Dublin, Ireland, and an adjunct assistant professor of oncology at Johns Hopkins. Today, we're going to be discussing some audience questions on lung cancer and immunotherapy from the World Conference on Lung Cancer. So, Julie, I might ask you the first question that came up from our audience. What patient and or disease characteristics do you consider when choosing either chemotherapy alone, chemotherapy with immunotherapy, or immunotherapy and immunotherapy combinations in patients with newly diagnosed stage 4 lung cancer with no targetable mutations that are PD-L1 less than 1%?
Well, certainly there are a lot of points to answer in that question. First, I'll take who should receive immunotherapy. I think those patients who should not receive immunotherapy include someone with severe autoimmune diseases that are requiring active therapy to keep them under control. Those are patients where discussions would have to be made if you're considering immunotherapy. Certainly patients with solid organ transplants where you don't have a backup, particularly patients with either heart, liver, or lung transplants, since there is a risk of adding immunotherapy and causing rejection in those patients. But for the majority of the patients, we would consider chemotherapy and immunotherapy or doublet immunotherapy plus chemotherapy in patients with PD-L1 negative disease. I think the biggest data is with either atezolizumab plus chemotherapy and bevacizumab in patients with non-squamous cell histology, or pembrolizumab plus chemotherapy in patients with squamous or non-squamous histologies. And then for patients with PD-L1 negative disease, if you want to use nivolumab and ipilimumab plus chemotherapy based on the CheckMate 9LA data, that certainly would be appropriate. I think with PD-L1 negative disease, we know that single agent IO is not appropriate in the first line treatment setting.
Great. And how do you think that changes if the PD-L1 score is intermediate, 1 to 49%? I
think that in patients with this tumor proportion score, you do have an option of using single agent immunotherapy, though based on the data from the FDA, chemotherapy and immunotherapy does seem to perform better based on their analyses. And then when you have PD-L1 positive disease, nivolumab and ipilimumab without chemotherapy is an option.
Yeah, I think those are great points. And I think the last question here, which you touched on actually in your WCLC presentation, how do you select patients that you think are a good fit for chemo-IO versus IO-IO?
I think that certainly for patients who have contraindications for chemotherapy, doing IO-IO is appropriate. I think for patients who have a heavy burden of disease and you need a high response rate, using chemotherapy and IO I usually pull that out for patients, but certainly it's a very individual decision about in each patient situation which option would be best. What about you, Jarushka? Do you have any thoughts about that?
Yeah, I agree. I think, there isn't a clear biomarker for IO. And then I think now we, need to also talk about chemo IO with 9LA, similarly without a clear biomarker. I think there are certain subsets of patients that are more open to having a chemotherapy-free option. And it's nice that we're able to discuss that with them based on the IO combinations. But I think it's important to also explain that something that's chemotherapy free doesn't necessarily come with no toxicity, and just that the toxicities are different. So that's kind of how I frame that conversation.
Well, great points. On a slightly different matter, how does the presence of brain metastasis in a patient with advanced non-small cell lung cancer impact your treatment decisions in regard to the use of immunotherapy-based regimens?
Yeah, I think this is a great question. I think we've known for many years that a sizable proportion of patients with non-small cell lung cancer have brain metastases, estimated at about 15% at diagnosis, and that these patients tended to fare worse in general. However, in the era of immunotherapy for lung cancer, these patients appear to have comparable outcomes and do really appear to benefit. And we have seen some dedicated subset analyses in the brain met population. One particular subset analysis was published by Marina Garasino and colleagues, which was a pooled analysis of the chemo IO combinations. And this showed a benefit across multiple combinations, Keynote 21, 189, and 407 for chemo IO with a hazard ratio of 0.48. Similarly, in the brain met population, patients who got ipi-nivo on CheckMate 227 had a hazard ratio of 0.68. And even in the single agent studies, Keynote 1, 10, 24, and 42, the patients with brain mets had a hazard ratio of 0.83. So I think, really reassuring in that regard. One very interesting area is the Empower Lung 1 study, cemiplimab with SRS in the PD-L1 high population. The brain met population actually had a hazard ratio of 0.17. So I think the era of immunotherapy has changed the discussion around brain mets a little bit. And we obviously welcome some of this progress in the field.
And what about when we're seeing toxicities? I think depending on the regimen you use, you can have immunotherapy related toxicities. And, one question was, how can you really distinguish between IO-induced pneumonitis versus radiation-induced pneumonitis when you have a patient receiving durvalumab after chemotherapy and RT in the stage 3 setting?
Yeah, I think this is a very clinically relevant question that comes up a lot in clinical practice and in our tumor boards. So right now, we don't have a very clear method to differentiate between the two. But basically, what we use to help us is that radiation pneumonitis tends to follow the radiation field or the radiation portal. So we kind of look for sharp edges and a pattern of pneumonitis that follows the field. Whereas IO-induced pneumonitis tends to be more common to be bilateral. It is important to distinguish between the two because the corticosteroid doses and tapers are slightly different. Is there a confirmatory test? We wish, and many of us are working on this, but as yet there is not. But there is ongoing work being done on this, and I would point the audience to a great paper by my colleague, Dr. Ron Vong at Hopkins, who did some work in this, looking at certain AI-based radiographic parameters that may help us to distinguish between one and the other, and ongoing work in that space is being done. Do I recommend biopsy for the diagnosis of pneumonitis? I think this is a contentious area. I think we know that pneumonitis is a diagnosis of exclusion, and in an ideal world, a bronchoscopy, particularly with BAL, is useful to truly rule out infection. And certain lung infections are more definitively ruled out with lung biopsy. But of course, in our patients, this does carry risk and would need to be discussed on a case-by-case basis.
Jarushka, Most of our patients will progress at some point on first-line therapy. And what do you do in the second-line setting for patients who progress after chemo IO? And is that different if you're giving IO?
Yeah, I think this is obviously one of the most clinically relevant questions and an area in which we need to innovate in this new era of giving combinations for lung cancer. I think in the setting of IO, it is a little bit simpler. In, say, a patient with a non-small cell lung cancer without a targetable alteration, we would want to go to platinum doublet chemotherapy. After that, we've had a long experience with those agents and know that they can confer benefit. I think after chemo IO is a little trickier, and we revert back usually to docetaxel or docetaxel with ramucirumab as a standard of care in that setting. But of course, clinical trials are fervently, enrolling patients in the setting and looking to answer these questions. I'm particularly excited about clinical trials that are trying to explore this from a mechanistic standpoint, such as the Hudson study, in which patients had rebiopsy and were directed towards certain combinations based on different proposed mechanisms of resistance to immunotherapy. And I think we await to see some of these results. What about you, Julie? What do you do in this setting?
Well, I think certainly if you're giving single agent IO or the combination, I feel comfortable going to platinum-based chemotherapy. And then if we've already used platinum-based chemotherapy in the first line setting, then going to docetaxel combinations. I think there's a lot of questions to try to answer in this area. Do you keep the immunotherapy going, just like patients with HER2 positive disease in breast cancer, where you always try to control that? Or do you stop and move on to something else? And I think there's a lot of different clinical trials we try to enroll our patients on. We have a particular trial that is combining immunotherapy with other therapies based on a patient's genomic profile. And certainly there's the National Lung Map study that is trying to do the same in order to try to get at these mechanisms of resistance. Obviously we'd love to be able to personalize therapy for our patients, but we're not quite there yet.
Totally agree.
So for you, Jarushka, thoughts about some of the future directions in the setting of immunotherapy? Where do you think we're going?
Yeah, I think I'll probably pick one area which, I've been working a lot on in the space of IO that I think is ripe for innovation. And we're learning from our colleagues in melanoma and other tumor types about how may actually bring about change in the field of immunotherapy is the field of the gut microbiome. So we have seen emerging data in melanoma that certain microbial subtypes may be associated with response to immunotherapy, and certain microbes may be protective against the development of immune-related toxicities, such as colitis. And then more recently, building on the experience in the early stage setting, giving immunotherapy in the neoadjuvant setting, which was pioneered by our colleague Dr. Ford at Hopkins, and now also others such as Tina Cascone at MD Anderson, we have seen that certain microbes are implicated in response and outcomes in early stage lung cancer with immunotherapy. And there are really exciting ways that we could harness the microbiome through probiotics, through genus-specific bacteriophages, through fecal microbiota transfer. So I think we will see a cadre of clinical studies that are looking at some of these ways of microbiome modulation and approaching host-based biomarkers to try to modulate our immune response. And I think that that's a very fascinating and unique direction for the field of immunotherapy. What about you, Julie? What do you think is a promising direction?
Well, I think trying to lift the tail of the curve for our patients with advanced disease and trying to really personalize therapy for them based both on their PD-L1 status and potentially other checkpoint pathways that are causing immune resistance. I think that may be the future. We're seeing different IO combinations in the first line treatment setting being tested in PD-L1 high disease. And then also even going to other 4-drug regimens in the patients with either PD-L1 negative disease or PD-L1 low positive. Certainly there's a lot of practical questions to answer here. But I think I'm hoping anyway in the advanced disease that different combinations will even raise the tail of the curve even further for our patients.
Absolutely.
Well, I want to thank my colleague, Dr. Naidoo, and thank you for joining us today in our Lung IO podcast in 2021 in response to our excellent audience questions from the World Lung Cancer Congress.
Thank you very much, Dr. Brahmer and Dr. Naidoo, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Understanding the Evolving Immuno-Oncology Treatment Paradigm in Non-Small Cell Lung Cancer, on the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.